Up to 10% of all broken bones in the human body happen in one specific place, the clavicle. Watch how the force in this collision transfers straight into the shoulder. That direct compressive impact is all it takes to snap the bone. This vintage sports photograph captures the exact mechanism for the first major demographic hit by this injury. Active individuals under 30 typically break their collarbones during high-energy athletic collisions or motor vehicle accidents. The demographic distribution spikes a second time much later in life. As seen in this photograph of an older woman navigating a simple step, patients over 55 frequently suffer the exact same fracture from low-energy falls. 87% of these injuries occur simply because a person falls directly onto their shoulder. The mechanical vulnerability of the collarbone ignores age, fitness, and lifestyle completely. When a patient arrives at the emergency room, the physical presentation is highly predictable. They clutch their affected arm tightly against their chest, supporting their elbow with the opposite hand to relieve the agonizing downward pull of gravity. Below the surface of the skin, the stakes are remarkably high. The jagged edges of a broken clavicle sit just millimeters away from the subclavian blood vessels and the brachial plexus, a massive nerve bundle controlling the arm. A routine break can heal naturally, while a slightly different angle can cause severe internal damage. Clinicians rely on a precise investigative pathway to determine exactly which scenario they are facing. This radiograph reveals the clavicle's normal anatomy. It is the single bony bridge anchoring the arm to the skeleton. Zooming in on the midshaft, the bone transitions from a thick, tubular shape near the chest into a flatter cross-section, creating a natural weak point. This middle segment is also the only area of the clavicle entirely devoid of reinforcing muscle or ligament attachments. It is structurally isolated. Evolutionary design traded heavy structural armor for a massive range of shoulder mobility, sacrificing raw strength for incredible flexibility. The result is a highly predictable breaking point, where roughly 80. This occurs when a sharp, displaced bone fragment pushes up against the skin from the inside, threatening to pierce through and create an open fracture. This historical photograph demonstrates the precise patient positioning required for accurate imaging. Standard chest X-rays taken while a patient lies flat often hide the collarbone behind the ribcage, causing doctors to underestimate the true displacement of the bone. The clinical solution is the Zenka view. Angling the X-ray beam upward completely bypasses the ribs, isolating the true fracture gap. Clinicians then organize this data using the Allman classification, mapping fractures across the bone's distinct medial, middle, and lateral zones. By capturing the exact degree of biomechanical chaos through standard imaging and classification, doctors establish the parameters required for a final treatment decision. When the bone fragments remain aligned, conservative treatment is the standard of care. Today, this means simple sling immobilization, allowing the bone to naturally remodel over a few months. Older methods, like the figure-of-8 brace, are rarely used because they cause discomfort and lower compliance. If overlapping fragments shorten the collarbone by more than 2 centimeters or present neurovascular risk, surgery is mandatory. Surgeons use an open reduction and internal fixation. Bolting titanium plates and screws across the gap creates a rigid bridge to physically overpower the pulling muscles. Repairing a fractured clavicle is ultimately an engineering problem. Clinicians must calculate exactly when the body's natural healing capacity is completely overwhelmed by its own deforming forces, and when metal hardware must step in to bridge the gap.
If you like this video, give us a thumbs up.